Hi, everyone, and welcome to the conversation. I'm Noelle Carmen, and with me today is Dr. Everett Lamb. He is the National Clinical Director for Niznik Behavioral Health. And today we are talking all things clinical with regards to substance use disorder treatment. Hey, how are you? Welcome to the show.
Good. Thank you for having me.
So let's just go ahead and jump right into the conversation. Can you go ahead and give us an overview of the clinical side of substance use treatment? I know that's a big ask, but let's all just get on the same page in terms of what we're actually talking about.
Absolutely. So, when we're looking at clinical care in the treatment environment, it's kind of putting to the side the medical things like medical detox and those issues, and instead focusing on psychologically, emotionally, and behaviorally the changes that we're trying to put forward in clients so that they can have the best chance of future success and recovery. So, when we look at the clinical aspects, the clinical side of it is everything from creating kind of the roadmap of where the client's currently at to where the client wants to get, right? And then developing the plan of how we're going to do that clinically to get the client from where they currently are to where they need to be and want to be.
So, a more personal question, wondering how you yourself got into this field.
Sure. So I'm in long-term recovery myself. So I started out going back through my education. I started when I had about 6 months sober, started back to school, received my bachelor's in social work. From there, went and got my master's in social work, worked in the field for a bunch of years, and then went back and got my doctorate in clinical psychology. So, me being someone who has been there, absolutely, and is in long term recovery was really a huge catalyst for me to be able to go through and help other people in a way that a lot of people may not understand if they haven't been in the same shoes.
And that's a really good point. Do you feel like a better clinician or a clinician who's able to have more insight is one who's actually gone through the addiction side themselves?
So the reality is, I think there's very few people whose lives haven't been touched in some way by addiction, and so I think that it's kind of both sides have their benefits, right? If I have someone who has a family member who's gone through addiction, that's a totally different perspective and a whole different set of insight than someone who actually has had addiction issues. So I really think that when we look at clinical roles, like both sides, people who are in active recovery themselves and people who come from families with addiction issues, both are really, really valuable tools.
So, when you're looking at the hallmarks of a stellar clinical program for substance use, what are the things that you're actually looking for? And that goes from the clinician side and also the programming side.
Absolutely. So when we're looking at programming, one of the things that I'm looking for in a really stellar clinical program is something that's using the science and evidence based, right? So I consider myself a scientist more than anything else. And so when we're looking at the best practices, the actual what the science drives as opposed to what opinions and what's been kind of treatment as usual, that makes a huge difference. We're talking about a field that's been around for 40 plus years. That there's a lot of places who are still utilizing the exact same tools that we were using 40 years ago without adapting to what is really going on and what the science drives. And so I think that when I'm looking for a stellar clinical program itself, one, it's holistic, it's covering all the different bases, right? So we're not just looking at it from a abstinence perspective, or we're not just looking at substance abuse alone. We're looking at all those kind of interarching like issues that become part of that, whether that's co-occurring mental health disorders, whether that's previous trauma, whether that's family of origin issues, whether that's identity issues, whatever that is, that we're looking at all those pieces together in order to serve the client in a holistic way rather than just taking one piece of that pie and treating that small issue. That really to me is what defines like excellent clinical service versus just kind of treatment as usual.
So, do you find that there's pushback from the clinical world in terms of maintaining the status quo? It kind of sounded like that's what you're hinting at a little bit.
So, I mean, and it depends, right? There's definitely some older facilities that this is the way we've always done it becomes the rule, right? And I'm a firm believer that good is always the enemy of great. Like, this is good enough. Why would we change it? When the reality is, like, if we're going to give the best services that we can, we have to do that using the best information that's available at the time. I mean, I go back to, the science of psychology and the multiple changes that have happened over the past 100+ years that psychology has been a field. And, we just look back 20 years at the difference between, using exposure therapy for PTSD versus EMDR now. And it seems, archaic and almost cruel that we did that previously, because as science changes, we have to change along with the times. So, as we get more information, we cannot continue doing the same things that we were doing and say this is best practices.
So in terms of red flags, as we're looking at perhaps more archaic ways of doing things rather than progressive ways, what are the red flags that you as a psychologist, you in the field, would give us in terms of identifying, okay, this is a great program. This program is maybe one we need to stay away from?
So anything that tells you that they're the only way to do something is definitely something that's a difficulty, right? Anytime someone's like, if you don't do it exactly this way, then it's not going to work. Any place that isn't willing to explain to you the why behind it, right? Like, this is why we do things this way, is definitely a huge red flag. Like, just do as we say and you'll get better, as opposed to actually explaining and walking you through what that treatment is, it's a disservice to the client and it's unethical. So that's definitely a huge red flag. If they're not willing to answer specific questions about what that treatment is going to look like, if they can't tell you which treatment modalities they're using, or use vague terminology, or aren't willing to explain that to you, if someone said, oh, we use CBT, well, what does that mean? And someone can't explain that, that's definitely something that I would look out for. Or in any of those, definitions of treatments that they use, whether REBT, rational emotive behavioral therapy, cognitive behavioral therapy, whatever they're using, if they can't explain to you what that treatment looks like, that's definitely a big red flag.
So in terms of guiding your clinical staff, what kinds of guidance and support do you offer as an individual who does that?
So one of the things I think is really important for me personally is finding my clinicians' passions, what they're passionate about when it comes to therapy, whether that's certain populations, whether that's certain, treatment types, whether that's certain types of therapies, figuring out what their passions are and then playing into that. I think that the more passionate we are about the population that we're serving, or the subset of that population that we're serving, the better job that we're going to do. Nobody wants a clinician that isn't excited to be doing therapy and helping their people get better. So it's definitely something that I play into. The other piece is, of course, as we've talked about, like education, continuing on my part of my responsibility is seeing what the best evidence-based practices are, and then making sure that we're utilizing those at each of our locations, so that that's coming down directly from me and seeing like, hey, like, this is what we're using, this is what we need to use. The other piece of that, I think the biggest piece, is like support and education, like helping our clinicians develop, helping our clinicians be better clinicians once if they leave our company, then that they leave our company actually better clinicians than they were when they came in. I think that that's one of those strong goals that I have for myself and for our teams, is that we continue to develop and become better and better. That's the goal for me personally and all the people that I supervise.
So I'm so curious how you identify a clinician's passion. And you and I have discussed previously in terms of also kind of the insight that a clinician would need, right? So like there's the education and you've got the degree, but then also identifying the passion, but then also recognizing that this clinician has got a tremendous amount of insight, whereas this clinician maybe needs to move in a different direction. So as you're guiding your staff, how are you making those deeper recognitions?
So, I mean, part of it, I think comes down to having like deep and meaningful conversations with our staff, having like realistic, deep and meaningful like goal setting. Like, what do you want out of this? And I think that starts, from really the hiring process of what are you passionate about? Where do you see yourself, as far as developmentally, professionally, where do you see yourself in a few years? How do you feel like this is going to help you get there? So I think that it really does start from the beginning of that relationship. I think the other part of that is creating a culture where they're able to discuss their passions without having them shut down, right? That we're open to that we're open to them exploring other avenues, that we're open to them seeing what's out there. And, if there's a certain treatment modality that they're really interested in, like facilitating that, helping them get additional education in that, helping them get certification in that. Because the more valuable they are as a clinician, the more value it feeds down to our client, and the better our treatment's going to be.
So let's talk pie in the sky. So, what is your vision? What's your pie in the sky vision of just a stellar clinical program, stellar clinical team?
So I think I've discussed what the clinical programs would look like is,
Yep.
very evidence-based, very client-focused, very solution-focused. I think treatment in general, for a very long time has been very problem-focused instead of solution-focused, right? One of the realities of, the human psyche is that it's much easier for us to run towards something than away from something and maintain motivation. So I think that piece of it of like, why are we doing this? Understanding back to that, like understanding the why, what's the purpose? And again, if the purpose, in the short term is just to avoid, legal issues, to avoid, try to rebuild family systems, whatever that looks like, that's fine. But really it's our job to dig down and get to that. What's that real internal motivation? Like, what's the why do you want to do this? Why do you want to move into recovery and get out of this cycle of continuing addictive behaviors and addictive use of substances? Like, what is it that you really want for your life? Like, I love doing this with clients and I love doing it with staff. Like, if we got it right, if everything goes the way we hope it does, what's that going to look like? Because that way it gives us, a goal line to move towards. I always say, I'm a visual thinker, so I use analogies a lot, but it's like early recovery is like being chased by a wolf and you're running away as fast as you can. Well, eventually you feel like you get some space and that motivation stops. And it's like, well, I'm safe now. And the reality is we're not any safer, just the wolf gets smarter and is hiding in the trees and waiting for us to make a mistake. So we can maintain that motivation of, instead of just running away, we see something we're running towards, whether that's an education, whether that's family, whether that's an occupation, whether that just is becoming a happy, healthy person who's comfortable in their own skin, right? Like, all those are very excellent goals that can help drive us to continue doing what we need to do in order to maintain our health.
From a clinical perspective, what are some of your greatest challenges as a clinician, as someone who leads clinicians, and then as someone who is directing, creating programming? I cannot imagine they stack up.
So, I mean, always, anytime that we're in a field where there's progressive change, it's always going to be fighting against the status quo, right? It's always going to be fighting against that idea of this is how it's always been done, that, human beings are very uncomfortable with change. We just are. It's the reality. So part of it is teaching our clients and our staff to be comfortable with being uncomfortable. I mean, the only way to grow is to get uncomfortable. And so that's really when we're looking at, keeping things the way that they've always been and not trying to find better ways to do things. It's really pushing against that discomfort is what's happening. It's like, I don't like this. This is different. And so getting over that hump, and I hate to sound like a broken record, but going back to the understanding of why we're doing that, I think is a huge way to overcome those obstacles of that pushback, or the, I don't like this, it's different, or I don't like this, it's new. But I think that that's always the piece, because, again, working in a field where things are ever changing. I mean, no day looks like the day before when you're looking at substance abuse treatment. You can have an easy day, you could have a more difficult day, but the other piece of it is over time, the treatment things that maybe last year were best practices may not be best practices anymore, as more and more science and evidence comes about. So it's pressing against that too. Like, it's the idea of like, oh, I know it all. Like, I'm great. Like, oh, this is the way you're done it. It always works. And I'm like, but it doesn't always. So it's kind of looking at that stuff and you really gaining the humility to realize that no matter how much knowledge we have in any field, we'll never know it all. We'll never ever know it all. And so there's always new things coming about.
Talk us through this term, full continuum of care. So when we talk about substance use treatment, we're always hearing that term, and it encapsulates a lot. Can you parse that out for us a little bit and define some of it, and just talk us through it?
So in order to kind of understand full continuum of care, you have to understand the different levels of care, right? So the highest level of care that we look at is detoxification, which is more medical than almost anything, right? That is getting the client physically safe in the environment to where the substances that they're using are not going to cause any severe medical side effects. Like, again, stopping using substances, no matter what they are, there's always going to be some type of side effects, be those physical or psychological. But the detoxification is the highest level of care, because that really is the part where there's the highest risk. From there, it steps down to the residential level of care. Residential level of care is where you are inpatient 24 hours a day in a safe, structured facility. You are going to programming throughout the day to learn and create that foundation for your continued recovery. It's when you're doing, groups and individual therapy and learning, psychoeducational stuff about the specific skills that you'll need in life, not just for recovery moving forward. From there, once you've kind of established that foundation for your recovery, we move into the partial hospitalization program, which tends to be, the majority of the day, 5 days a week, that you are in a therapeutic environment. In the evenings, you go home. Maybe you're starting to look for work, have weekends with your family, whatever, but you are still having the majority of your time during the week in that structured environment to help transition you. So when we're looking at these levels, one of the big things you have to look at is, if stopping treatment at any of those levels is a pretty huge cliff to jump off of. To go from 24 hours a day in treatment to PHP, you're back out in the community, you're back out in the real world, as we like to call it, where, inpatient, there's no drink menus on the tables. There's nobody walking by with, a wine list. Like, there's no one, no availability of substances. You're not able to, go down to whoever's house and pick up whatever substance it is that was your favorite. So in PHP, like, all those temptations and all those issues and triggers are right back there, right? Because we don't teach people how to just completely avoid it, because that's impossible, right? If I need to get gas at a gas station, I am more than likely going to be able to interact with alcohol and the coolers there. So it's not something that's an avoidance issue, it's learning how to cope with those. So from the PHP is another level step down to our intensive outpatient. Intensive outpatient is 9 to 10 hours of group a week, individual sessions. You're coming multiple days a week to a safe place, but you have the vast majority of your time back to transition back into real life. The cool thing about the PHP and the IOP level of care is, when we're looking at residential treatment, we're really looking at hypotheticals, right? Vast majority of what we're talking about is stuff that might happen once you leave the facility. things that might happen after treatment. During PHP and IOP, we're dealing with those issues in real time. And it's probably, I mean, although lots of people don't look at it that way, it's probably the most important part, because it's when we're dealing with real issues in real time. Instead of like, oh, it might be that, you know, you have an argument with someone and you feel like you want to go drink or use. Now we're talking to you when you're like, man, I had an argument with my boss yesterday and I really wanted to go drink afterwards. And getting the tools to actually help in these real life, real world situations. So from there, the step down is to outpatient counseling, which is, you know, being referred to, you know, outpatient counseling maybe once a week, you know, once every other week, of seeing a clinician that we know well and are referring out to, for them to continue that process so that they still have someone to talk to that, you know, doesn't have a dog in the fight. It's great to have like family supports and friend supports, but all of them kind of always have underlying stuff there. Talking to a clinician, it's someone who does not have any interest whatsoever besides getting that person better, which is a really valuable tool to have. So when we're talking about continuum of care, we're talking about everything from that detoxification level of care all the way down that intensive outpatient level of care.
So can we talk a little bit more specifically about tools? We often hear also this idea of the toolbox, and the clinicians are putting tools in your toolbox for you to go out into the world. Can you talk to us a little bit, boots on the ground, as to what that really looks like?
Sure. So, I mean, again, the tools that are valuable to people clinically are going to be different based on that person's individual need. That's why everyone has their own individualized treatment plan, right? Because it's based on what that client's specific needs are. It may be that the need is that they need to be more social. It also may be that they need to have better boundaries and be a little less open with every person around them. It's going to be different for every single person. So those tools are going to look different, but in general, there's some general tools that are really valuable to everyone. One is, you know, communication skills, the ability to build real supports, to see healthy boundaries so that we are able to build those trusting relationships and not get into these cycles. It's a really common cycle in addiction with trust, where people don't trust people because they put themselves into positions to trust untrustworthy people who haven't earned that trust yet, right? And then they get injured or hurt by them. So then it tells them, well, I can't trust anybody. I'm like, well, yes, because you continue putting trust in untrustworthy people. So looking at tools like setting boundaries and how to build trust slowly over time, rather than just, you know, throw all my stuff out there to a person, is a valuable tool. Coping skills, learning how to like actually cope with emotion. So there's a big misconception, I think, across the board with what coping skills are and aren't. So coping skills are skills that specifically help you to deal with and get through emotions safely. A lot of people refer to things that are like distraction skills as coping skills. Like, my coping skill is I'll sit and binge watch Netflix. I'm like, does that help you get through the feeling? You get on the other side of that feeling and through it. Well, no, as soon as the, you know, series is over, then I'm right back to feeling how I felt. Then that's a distraction skill, not a coping skill. So we specifically work to build coping skills. Not every coping skill works for every person. So that's kind of part of what we boil down, is figuring out what skills actually work for our clients, that specific client, and what skills don't. I think it's just as important for people to figure out what coping skills don't work, so they're not wasting their time, as opposed to what coping skills do work, right? And it's also looking at things like actually addressing our defense mechanisms, seeing how, you know, those kind of, I call it default natural, like, right, a default natural reaction to things, how those are usually lying to us. You know, that's one of my commonalities that I say is, you know, my brain loves to tell me stories that aren't true. Like, it's just a story my brain's telling me that is not factual. And so the more I can metal down that and figure out, like, where is that coming from? Why am I feeling this way, right? What's the defense around it? Then I can alternate into some like changing thinking. I can alternate into like challenging some of those like negative cognition, some of those ideas that I have that aren't realistic, which is going to lead to less emotional consequence for me. So that's just a handful that, you know, generally we give across the board, but there's dozens and dozens and dozens of others that are completely based on what that client's needs are that we help them to identify. Now, the one piece of it that I always say is we can offer all the tools in the world. It's up to the clients themselves to actually apply those tools, right? I can hand someone a hammer, but I can't use it for them. And that's really what we're doing as clinicians is handing these tools out so that the clients are able to use them in real time.
As a scientist in a behavioral health field, how do you measure success when you're looking at substance use disorder treatments?
So I think that's a very loaded question because there's a bunch of ways that we can do
You're
that.
welcome.
Thanks. No, I mean, there really is a bunch of ways that we can look at that. Like it tends to be that we tend to look at successes as all or nothing, right? Is that client abstinent? Is that client, still staying sober long term? Is that client, avoiding these behaviors altogether? But I think it's really on a continuum, right? When we talk about even relapse is an upward cycle. Every time someone relapses, the natural reaction is for people to shame them. But the reality is, if we sit down and ask them, what did you learn this time around, right? Where was that stumbling block for you this time around? Then we're able to actually make it more likely that they stay sober the next time around. And so it really is an upward cycle of, you learn something new each and every time, which gives you a better chance of staying sober. I know a lot of people have difficulty with, they've been to treatment this many times and they just keep relapsing. I'm like, well, but the question is, they've learned more and more each of those times. That's going to give them a better chance at long-term success. And so that's one of the things that we get to look at with that as well. So I don't think that just absolute abstinence definitely is one of the goals for a lot of people and one that we help them try to achieve. But I think the other aspect clinically for me is looking at, how many of these skills are they able to use? Are they still having difficulty with past traumatic experiences that we've helped them address? I think that, it's not just a binary, like yes or no, they're sober. I think that there's, a lot of gray area there that we can actually see some progress. And I think it's difficult for a lot of people or a lot of centers because they judge primarily on that,
Yeah.
If they're sober, they're not. And I think that there's a lot of gray area that shows that, we are making a big difference in their lives. It may just be as simple as, how long were they out using this time before they decided to get sober again? If that time is shortening and shortening, like there's something happening there. There's definitely some change happening there.
At the foundation of everything that we're talking about, it all comes back to leadership. So when you're talking about being a clinician or leading clinicians, what are some of your notions of excellent leadership and how that kind of intersects with being an excellent clinician?
So I think that part of it is seeing who your clients are and who you're serving, right? So for a role like mine, not only am I serving and trying to help our clients that are in treatment, but I'm also serving my clinical directors and clinical teams to make sure that they're getting the tools and education and support that they need in order to be the best clinicians that they can be. So I think that it definitely, the higher you go with leadership, the more broad that base gets, because you have to kind of view it from this, 5 or 6 steps back instead of right up in it. It's like, how is this going to help my team? How is this going to help the client? And I'm a really firm believer that most of the things that we do to improve clinically are always going to improve the clinical stuff for our clients, no matter what that is, right? So if I'm helping one of our clinical directors at a site to become better at whatever it is that they're trying to advance themselves in professionally or whatever they're trying to learn, that information is going to help trickle down to their staff, which is then going to trickle down to the client. So it really does make a huge difference. And again, I think that it's also starting from both ends, right? So I always start anything with a goal in mind. And then I also start it with the client in mind. So when those two kind of meet in the middle, it makes a huge difference as to like how these effects are positive on those clients' lives and on their treatment experience. Can I answer that?
You did, and you did an excellent job. So my final question is really about a message of hope. As humans, we're always changing. We're always forced into making choices with regards to these things. What is your message of hope for us?
Change is inevitable and it's not scary. We tend to look at anything happening differently as being negative. Change is a positive, right? Thank goodness I'm not where I was at 19 or 20 years old. Thank goodness I'm not where I was a year ago. So I think that that's the big message of hope is, change is possible. Even if you feel like you've been stuck in the same place for a long while, not only is change possible, but change isn't a scary thing. It's almost always going to lead to like long-term gains for us, right? So I think that that's one of the things that we forget. Getting to the edge of that comfort bubble that we have where we start getting uncomfortable is what really allows it to grow. So I tell people all the time, as human beings, we were not created to be comfortable. If you look at 200 years ago, just a simple 200 years ago, where you would have to go out to the well to get water, you would have to, if you wanted to eat something, you either had to kill it or grow it or trade with other farmers who had it. Like that's been the natural state that we've been at for most of humanity. So realizing that like this idea of I need to be comfortable and I need to not feel pushed and not feel uncomfortable, it really is diametrically opposed to what we're designed for and who we are as people. So embrace the change. Like it's a good thing.
Embrace the change. Dr. Lamb, thank you so very much for taking some time just to chat with us and talk about your expertise in substance use, the whole clinical side of it. Really appreciate you. And I want to thank everyone for tuning in to the conversation. Have a wonderful, wonderful day.
Thank you for having me.